And I said yes, and he said, how much? And I said, a drink or two at night. And he said, is that all? And I said, it is. And I envisioned, I knew my own drinks were in glasses that were very large tumblers full of alcohol.
I used to just lie, you know, and it was easier to say I didn't drink at all, and that was never picked up.
Alcoholism is a physically and emotionally crippling, potentially fatal disease. It is only recently that it has begun to stir the interest it deserves in the medical community at large. We asked Dr. Stanley Gitlow, former president of the American Medical Society on Alcoholism, interviewed by Dr. Susan Deakins, Dr. John Severinghouse, coordinator of medical care at the Smithers Alcoholism Treatment and Training Center, the Roosevelt Hospital in New York, and a group of recovered alcoholics to share their insights and feelings on the subject of alcoholism. Here with us also is actor and recovered alcoholic Patrick O'Neill, talking with doctors who choose to learn more about the subject.
Well, one thing you can rely on, doctor, you've been lied to. I've done that myself, did a lot of it. Lied to a lot of doctors, lied to my family. Maybe more important, I lied to myself. What I didn't know then was that lying, or denial as it's called in more sophisticated circles, is a symptom of the disease of alcoholism. I know that you're all not being served by not being told the truth, but what I'd urge you to do is to look past the lie. In other words, I've lied to you, and I'm counting on you now with your patients today to see past that lie and have the wisdom to get that that's a symptom. Look for other evidence, not just what you hear. Maybe go for what you feel. So one of the purposes of our rap here is to talk about ways in which, if you don't already know, you can look for some of the subtle ways of getting past my lies and other alcoholics' lies when you see them.
In our country today, I think there's good reason to believe that in the age range of 15 to 45, alcoholism is probably the biggest killer. If we look at the accidental deaths alone, 50% of all the motor vehicle deaths amounts to something like 25,000 people a year. Somewhere in the neighborhood of about 60% of all the drownings, and in excess of that for those people who die by fire. Burns. Then to that you can add 11,000 cirrhosis deaths per year, 85% of which are related to alcohol use. The numbers are just staggering, so that as the size of the problem, the magnitude is enormous, and yet the likelihood is that most physicians are not actively diagnosing the illness or treating it.
Well, why is that so many people are seeing alcoholics and yet not seeing alcoholics?
Alcoholics can at times be extremely trying to work with. They are enormously unhappy, they're suffering, they're racked with pain, and their only way of really expressing this is, if they're with you, to you. Many of us are concerned with people who are suffering, and you'll never see a patient who suffers any more than the patient with alcoholism. Nonetheless, we can be enormously effective if we overcome or break through the denial, the anger, the resentment, why has this happened to me kind of response of the patient. If you can break through that, you can have a patient whose life has changed so completely that the sense of reward for the physician is certainly there.
I had the feeling, both in the hospital and when I came out, that these were two doctors who really cared about me, who really cared about my problem, and who really wanted to help. And this touched me very much, and I responded to it.
We have preconceived notions about the alcoholic, Skid Row rummy, making up all of something like 3 or 4 or 5% of all the alcoholics. Most alcoholics don't look that way. If you want to know about alcoholism, then you've got to go to the epidemic. The only problem with alcoholism is we're living in the epidemic. We're right here. They're all around us. But they're so busy denying, and we help them a little bit, that we don't see it. If we want to see these patients, we have to see them in recovery. And the only way to do that is either in a rehab facility that's set up deliberately to treat the alcoholic, or in Alcoholics Anonymous.
What kind of things might the physician, hear if he went?
They'll see the alcoholic as a human being with a disease. He'll hear about the attitudes. He'll see the individuals and see what they do about their own illness, their reaction to their illness.
As far as the public knows, and as far as someone like me knows who doesn't know you, to have had a very successful career. I would just wonder if that's typical of alcoholics, in the sense that they can keep functioning at the level you appear to have kept functioning.
Now, you can't always judge it in some of the classic terms, like job drop-off, or, we all have this kind of cliche notion that an alcoholic ends up in the gutter. Well, I was making more money I've ever made in my life when I stopped drinking, because I was very careful never to drink when I was working. I mean, I'd be on a movie, for instance, and I'd have the schedule in front of me for the whole shoot, and I would go in training for the 2 days before the big scene. Not drink at all, run, sleep a lot, get rested, and get ready for the scene. The minute the scene's wrapped, celebrate. There are people who have all those obvious signs, like their career starts to fall apart, the marriage starts to fall apart, the whole world starts to fall apart. That's traditionally the sort of classic definition of an alcoholic, I believe, that when their lives become unmanageable in some way.
Alcoholism is a disease characterized by the repetitive ingestion of any sedative drug, alcohol being just one, in such a way as to cause interference with some aspect of the person's life, be that their interpersonal relationships and marriage, their career, their health.
What is social drinking as compared to alcoholic drinking, and how do you go about making that distinction?
You can't use quantity of alcohol ingested as a mechanism of determining whether someone is an alcoholic. Rather, how does it interfere with the quality of their life? What is it doing? Are they using the alcohol anyway? This is the critical issue.
Even though I did not overnight turn into any definition of an alcoholic that we're talking about today, I did drink alcoholically, meaning I drank compulsively. I drank too much. I drank for a change in the head. I drank to blank out or get rid of things. I drank as only an alcoholic drinks, even in the beginning, the very beginning.
What are reasons that people start to drink?
I've heard all sorts of reasons. After almost 30 years of treating alcoholics, I must confess that I don't know why alcoholics drink.
An alcoholic drinks because he's an alcoholic.
I didn't get drunk for little things. They were always great big things. Big unhappiness or big happiness,
I drank because I drank, and I didn't know why I drank as much as I did.
I related it to the work, that I'm working long hours and so forth, and so, I've earned it, kind of thing. So a variety of stories as they went along, none of which probably really relate to the real reason.
Every time they start to drink, they'll tell themselves that they will be able to stop, and they can't. And every time they have a drinking bout, it ends up in just as much pain, suffering, and disaster for them as the previous one. And they suffer it over and over and over again and don't stop. I've looked at it now for many years, and I'm convinced that certain people have it and others don't. This doesn't mean that there aren't other things necessary for the production of this illness. I think that it's probably multifaceted insofar as etiology is concerned. The patient will usually recognize that their drinking is a little bit different than the next person's. So what they end up doing is surrounding themselves with the type of people they want, who will drink like they drink. And they marry that type of person quite commonly. They go into work with those kinds of people, and they hang around the bar cars or in the local bar with that sort of individual. In actual truth, they are relating to very, very few people. They find that their initial personality very often tended towards isolation, and now the drinking and its complications necessitates isolation because their behavior pattern is so anomalous.
I mean, I used to go to my office and lock the door alone a day or two at a time. I'd go to a strange town.
So they become more and more isolated. And by isolated, I mean, again, less and less meaningful, gut-level, communication with other human beings. In fact, it points, as an aside, to the major thrust in the treatment of alcoholism, and that is to fracture that isolation, to put human beings back into contact with other human beings. The establishment of a relationship with that human being is the initial fracture in the disease. The first step is that you have to be suspicious that you may be dealing with a person with alcoholism. And there are innumerable ways of doing that. Very first is for someone whose life is not going along well. He's having trouble with his job, he's moving jobs, he's seeking geographical changes, he's moving marriages, moving friends, can't get along all that well with this family relative or that one. If you see a person whose life is just a mess, so to speak, first thing to think of is alcoholism.
And I was coming down a steep hill. Instead of putting my foot on a brake, I put it on a clutch and ran into a car at the foot of the road. And the police were there, and they didn't think, how did it happen? I said, the road was wet, and they bought that. See? But the car was a mess, and I walked away, and everybody thought I was all right. I was stoned.
Individual who has burn marks between their two fingers when they let their cigarette burn down to the bone practically, people don't do that unless they're inundated with a soporific of some sort. Individuals with multiple injuries, multiple fractures of different times, people who look thyrotoxic, they look hot, their blood pressure's up, they're tense, they have a fine tremor, they're sweating, their skin is blotchy. They look for all the world like an individual with thyrotoxicosis, and yet you make the measurements and their T4s and T3s are perfectly normal. Think of alcoholism. People who are being treated for other illnesses like peptic ulcer or high blood pressure or tuberculosis, but you don't ever seem to be able to keep them in a state of remission. Something always is coming along and throwing them out of kilter. Think alcoholism as a major interference with their compliance with treatment for other illnesses. So there are many things that will suggest it above and beyond a big liver and an abnormal SGOT.
When does the alcoholic finally realize that they're in trouble?
That is liable to occur when they're suddenly acutely ill, time of a severe accident perchance, some sort of a critical turmoil at home. The spouse suddenly says, "I've had enough," and walks through the front door. The boss on the job says something rather vigorous, like, "Why don't you go look for another job?"
I felt that it was absolutely the last mile. I would have done anything that anyone had asked me to do. I had reached the point in my drinking where death was preferable to anything else.
The question comes up then as to how do you approach this individual in order to get more of a story from him? Obviously, they're going to evade. They'll lie straight out as much as they can in order to continue to do that which they know they've got to do.
A doctor always questioned me about my drinking, but I have the old denial, 2 before dinner, perhaps a drink at lunchtime, and that was about all.
The best way that I know of interfering with that is to try and demonstrate to this human being that we are understanding, sympathetic, and knowledgeable. The diagnosis requires that I make a connection between the use of the sedative agent and some aberration in the quality of life. So I go first for finding the aberrations in the quality of life. Incidentally, I might add, do you drink or smoke, in a totally non-judgmental manner. I'm not interested in judging him, I'm interested in diagnosing him.
Where do you move from there?
Major thing is to try to attempt to motivate the patient. First, I have to so-called confront him. Now, a confrontation is not hitting him with a 2x4. The confrontation is hopefully done in such a way as to lay the groundwork for the patient to enter into a therapeutic plan that you're going to suggest.
When it finally happened, I'd already, what they call, bottomed out. I had been through such incredible pain that it was absolutely the best news I'd ever heard, because I thought I was crazy. See, it's a great relief to find out it's only alcoholism.
The major issue then is to attempt simultaneously to delivering your verdict, which it is, and a very unwelcome one, obviously, simultaneously to deliver this with hope that, yes, you appear to have this illness, but recovery is very possible.
I'd run out of choices. So when I had a doctor standing at the foot of my bed in the hospital saying, guess what? You've got a disease, and it's called alcoholism, and I have an answer for you. And it's not going to be easy, it's going to be tough, and it's going to take a long time. That didn't bother me. I said, you mean no more of that bathroom floor pain, not remembering where I am, disappearing for 2 or 3 days at a time, messing up other people's lives? You mean that's all I have to do is do this little stuff? And he said, yep. And I said, great.
One of the easiest techniques is to attempt to indicate to this patient, once we have made a diagnosis, that they don't know all there is to know about their problem. They think they do, but they've been so isolated with their problem, they really don't. But there are things about its treatment and the behavior of the illness that they are not aware of, or at least not consciously aware of, and that knowing these things, there are outs.
I was seeing a doctor who was a specialist in alcoholic treatment and a therapist, and he helped me in a number of ways. The first one was convincing me on an intellectual level that I was an alcoholic, and things that was never going to change, and things were going to get worse. That it was going to be, it's a progressive disease.
After diagnosis and confrontation, you may refer him for therapy elsewhere. You may, on the other hand, choose to detox the patient and refer the patient for further care. Or you may decide to administer the total care for the alcoholic yourself, the acute care and the definitive care. In any event, you may utilize certain support structures that you have within your own community. These might include AA, an alcoholism treatment facility run by private or city, county, state facilities. You may utilize a treatment facility that you can attain or reach vis-a-vis the local chapter of National Council on Alcoholism. If you're going to detox the patient, certainly in an inpatient facility, then you may be free to utilize one or another of the sedative drugs, sedative or tranquilizer drugs. On the other hand, using such agents for the outpatient alcoholic is fraught with danger. Cross-addiction is very common, and you will frequently get the patient into more difficulty than the agent is worth. My patients have referred to some of the benzodiazepines as just the very driest of martinis. Insofar as useful medicinal agents, on the other hand, the use of disulfiram suggests itself in many areas of the treatment of the alcoholic. You may use disulfiram in order to gauge motivation, to assist the impulsive drinker, to take the alcoholic over acute periods in their course, death in a family or travel or what have you. You may use it for its usefulness in probation or parole. It can be used to assist in the care of the family, where the anxious spouse is markedly allayed by the fact that they know, she or he knows that the patient is on Antabuse.
And I stayed with Antabuse because I traveled quite a bit in my business. And on planes, I was most tempted to take a drink. But with the Antabuse, I wouldn't dare.
I think the physician must bear in mind that success may be immediate, it may be somewhat delayed, but no matter what you do, as long as what you do is honest and caring and accurate, the likelihood is that that patient has a greater chance for a recovery either right then and there or at the next confrontation with the next physician that he may see.
I call it a moment of transformation. I went from one kind of life and headed toward a whole other kind of life in that one moment, which came right out of the doctor.
One of the most rewarding things for me has been that I really don't know an area of medicine in which people who are so sick can get so well. It's really astonishing to follow a patient through their recovery from alcoholism.
If I compare the patient with duodenal ulcer that has a breakdown this year, and he follows his diet for a while and he gets better and he gets a breakdown again 3 years from now, I certainly relieve his pain and his suffering, and I do a good thing for him, but I don't fulfill anywhere near the kind of role that I do with the individual who's out of work, whose life in every of its, one of its avenues is coming to a complete screeching halt, and who suddenly turns around and capitalizes on his abstinence that's associated with his recovery from alcoholism. He gains his physical health. He begins to go back to work. His relationships begin to flower. His entire life changes its characteristics. And both for the patient as well as for the physician, that offers an enormous reward.
Information relating to major side effects and contraindications of Antabuse, disulfiram. Contraindications. Disulfiram is contraindicated in patients who are receiving or who have recently received metronidazole, formaldehyde, alcohol, or alcohol-containing preparations. Antabuse is contraindicated in the presence of severe myocardial disease or coronary occlusion, psychoses, and hypersensitivity to disulfiram or to other thiuram derivatives used in pesticides and rubber vulcanization. Warnings. Antabuse should never be administered to a patient who is in a state of alcohol intoxication or without the patient's full knowledge. The patient must be fully informed of the Antabuse alcohol reaction. He must be strongly cautioned against surreptitious drinking while taking the drug, and he must be fully aware of possible consequences. He should be warned to avoid alcohol in disguised form, such as in sauces, vinegars, cough mixtures, and even aftershave lotions and back rubs. He should also be warned that reactions may occur with alcohol up to 14 days after ingesting Antabuse. Major adverse reactions: optic neuritis, peripheral neuritis, and polyneuritis may occur following administration of Antabuse. Skin eruptions, mild drowsiness, metallic or garlic-like aftertaste are the most frequently reported adverse reactions. Also reported are psychotic reactions attributable in most cases to high dosage, combined toxicity with metronidazole or isoniazid, or to the unmasking of underlying psychoses in patients stressed by the withdrawal of alcohol. Other adverse reactions have been reported with the use of disulfiram in addition to those mentioned in this presentation. A complete statement of the warnings, precautions, contraindications, and adverse reactions is contained in the full disclosure information which accompanies this audio-visual presentation.